Mitral stenosis MS severe, valve area, 1 cm to the power of 2 on echo. Pathophysiology: LA pressure, pulmonary congestion, pulmonary edema, pulmonary HTN, RV failure, dyspnea at rest. Sign of severe disease: tachycardia, arrhythmias, diastolic filling. CO management: rate control critical, Greek letter beta blockers, digoxin for tachyarrhythmias. If pulmonary HTN present, consider pregnancy termination. Severe MS. Balloon valvotomy may be needed. Vaginal delivery preferred with titrated epidural. Invasive BP monitoring. Pulmonary stenosis. PS overview: 10% of congenital heart disease cases may occur in isolation or with tetralogy of Fallot concerns, often asymptomatic but can cause RV strain failure. Risk during labor due to RV workload management. Balloon valvuloplasty: if symptomatic or RV failure develops. Labor goals: maintain RV preload and support RV function. Maintain 55 afterload. Vaginal delivery plus epidural is optimal. Pulmonary hypertension, PH, in pregnancy. Extremely high maternal mortality up to 50%. Pregnancy is often not recommended. Contraception advised. Can be primary or secondary to cardiac, respiratory, thromboembolic, hepatic, or drug-induced causes. Right ventricular failure is the major cause of death. Pathophysiology: pulmonary vascular resistance, PVR, right ventricular RV afterload. RV cannot adapt to cardiac output or the reduced compliance of the pulmonary vasculature. Worsened by hypoxia, hypercarbia, acidosis, hypothermia, and high airway pressures. Symptoms: signs, symptoms: dyspnea, fatigue, syncope, chronic cough, hemoptysis. Signs: tachycardia, cyanosis, raised JVP, RV heave, hepatomegaly. Antenatal management: close follow-up in specialist cardiac obstetric centers. Consider pulmonary vasodilators e.g., iloprist. Regular echo, ECG, and exercise testing may help guide timing of delivery. Intrapartum care: vaginal delivery preferred with low-dose epidural to reduce stress and hemodynamic fluctuations. Avoid active pushing, use assisted delivery. Elective C-section may be chosen if early delivery is required. Avoid single-shot spinal, risk of severe hypotension. General anesthesia, use with caution. Blunt pressure response to laryngoscopy. Avoid ephedrine. Tachycardia, use phenylephrine metaraminal as vasopressors. Careful fluid balance to prevent pulmonary edema. Avoid drugs that increase PVR or tachycardia, e.g., high-dose oxytocin, ephedrine. Postpartum: most maternal deaths occur 2 to 9 days postpartum. Monitor in HDU for at least 72 hours. Restart anticoagulation if needed. Maintain good analgesia to prevent stress and tachycardia. Cardiovascular system returns to baseline over 6-8 weeks. Eisenmenger syndrome definition: end-stage congenital heart disease with irreversible pulmonary hypertension and right or left shunting, e.g., VSD, ASD, PDA. Shunt direction depends on PVR, SVR ratio. Pathophysiology: PVR leads to shunt reversal, hypoxia, and cyanosis. Hypovolemia, hypotension, and increased intrathoracic pressure worsen the right to left shunt. RV failure and systemic hypoxia are common causes of maternal mortality. Risks: pregnancy is contraindicated in Eisenmenger due to very high mortality, 30 to 50% or higher. Even mild activity or hemodynamic shifts can cause decompensation. Management: preconception counseling is essential. Termination may be advised. Same intrapartum and postpartum considerations as pH. Avoid air bubbles in IV lines. Risk of paradoxical embolism. Maintain adequate preload and SVR. Careful titration of regional anesthesia. Avoid sudden vasodilation. Ischemic heart disease and MI in pregnancy. Overview: leading cause of maternal cardiac death in the UK. Often presents in third trimester, labor, or postpartum, periods of peak cardiac stress. Risk factors: obesity, advanced maternal age, high parity, pre-existing hypertension, smoking, type 2 diabetes, family history of cardiac disease. Clinical presentation: typically, chest pain, ECG changes, troponin atypical. Epigastric abdominal pain. Diagnosis: high index of suspicion in women with risk factors plus chest pain. ECG and troponin are essential. Coronary angiography if IHD suspected, confirmed. Management: primary PTCA equals treatment of choice. If PTCA unavailable, thrombolysis is not contraindicated in pregnancy. Postpartum: avoid ergometrine, causes coronary vasospasm. Caution with uterotonics, general management in pregnancy with cardiac disease monitoring standard, BP, SPO2, 3-lead ECG. High risk, invasive BP monitoring useful, CVP pack use controversial alternatives, long antecubital lines for vasoctives and CVP, delivery planning consultant-led care in a tertiary center with HDU facilities. Goals, reduce maternal stress, maintain placental perfusion. Labor early low-dose epidural, minimizes catecholamines and tachycardia. Assisted second stage, reduces pushing effort. Caesarean section indications, obstetric decompensation, high-risk lesions. Regional preferred but, avoid single-shot spinel use incremental epidural, CSE, or spinal catheter. GA, use if required for complex procedures or poor cardiac reserve. Blunt laryngoscopy response e.g., alfentanil 10-20 mcg/kg, anesthesia considerations balance, SVR drop, regional, versus contractility depression GA, anticoagulation status, warfarin LMWH, airway issues, procedural needs, maternal fetal risk and preferences, anticoagulation, warfarin, avoid in first and third trimesters, LMWH, safe throughout pregnancy. Prophylactic LMWH, raw spinal 12 HRS after last dose. Therapeutic LMWH, raw spinal 24 HRS after last dose. Post-neuraxal dosing, resume LMWH after 4 HRS, uterotonics oxytocin, avoid bolus, give 5U over 5 to 10 minutes infusion, monitor closely. Ergometrine and carbaprist, avoid in cardiac disease, especially pH. Non-pharmacological, uterine massage, balloon tamponade, B-Lynch sutures, internal iliac ligation, hysterectomy as last resort, endocarditis prophylaxis. Infective endocarditis prophylaxis guidelines 1. Not routine for obstetric or gynecological procedures. 2. Only for high-risk cardiac conditions, prosthetic valves, previous i.e., certain congenital heart diseases, and cardiac transplant with valvulopathy. 3. Dental procedures, prophylaxis warranted in high-risk individuals for gum or mucosal manipulation. 4. Non-dental procedures, no prophylaxis unless active infection. 5. Obstetric patients with high-risk cardiac disease, no routine prophylaxis unless ongoing infection. Laryngectomy, Oxford, procedure, excision of larynx epiglottis and glottis, with endstomal tracheostomy duration. 3 to 4 hours. Pain level, severe, position, supine, shoulder pad, head ring, head up tilt. Blood loss, moderate to substantial, cross-match 2 units. Airway, IPPV via oral et, north facing. Converted to tracheostomy intraoperatively monitoring access, arterial line urinary catheter CVP line, for prolonged surgery or cardiac indication. Preoperative careful assessment of airway. Some degree of airway obstruction compromise, likely dyspnea, orthopnea, stridor, dysphagia, take cancer-related history, WT loss, nutrition, chemoradiotherapy, usually smokers, CVS, respiratory system problems and malnutrition common. Patient likely to have had recent GA for diagnosis, to guide airway management, beware if some time has elapsed. If no recent GA, assess the airway as for microlaryngoscopy. Discuss implications of tracheostomy preoperatively, communication, secretions, coughing produced by tube. Speech therapist will do much of this. Discuss regarding fiber optic, if no stridor, investigations, X-ray chest and neck CT chest, extent of mass, nasoendoscopy, IDL, fiber optic laryngoscopy and electrolytes, malnutrition. Other diseases-related investigations, pre-op optimization and management, multidisciplinary approach. Involving respiratory therapist, intensivist, anesthetist. Informed high-risk consent. Complications of difficult airway and tracheostomy, respiratory optimization, deep breathing, incentive spirometry, chest physiotherapy, smoking cessation, continuation of medications or additional therapies if needed. Perioperative 2 large bore IV cannulus monitoring, standard ASA 1, 2 and UO, ART line, CVP if major fluid shifts expected if indicated, tail femoral access or via subclavian or antecubital veins, insert fine. Bore NG feeding tube at induction, and fixed securely, can be sutured to nasal septum. Induction, inhalational induction followed by intubation and then tracheostomy. Have airway agents, video laryngoscope bougie style it even a foy, depends on tumor in case of stridor and ryak of compromising airway wath the foy or inhalational. Tracheostomy indicated under LA when changing to tracheostomy tube. See precautions for tracheostomy, though endstoma makes tracheal access safer and easier secure tubes lines. Maintenance warming blanket and fluid warmer. Long tubing needed for breathing circuit and gas sampling tube. Remifentanil infusion IDL substantial blood loss can accumulate under drapes at back of neck and may not be apparent until end of case. Antibiotic prophylaxis for at least 24H. During surgery, long tube, armored or special preformed via tracheostomy is useful to enable surgical access round stoma, then changed for standard tracheostomy tube at end. Extubation, gentle suction via tracheostomy, make sure of stable hemodynamics and ventilatory parameters, on emergence glycopyrrolative secretions and opioids to blunt cough. Postoperative HDU IDL humidification and regular suction essential blood, secretions. Rehabilitation, crucial role of RT regarding tracheostomy. New tracheostomy produces protracted coughing, morphine, benzodiazepines or low-dose propofol useful for control. Analgesia with PRN morphine IVN, plus PRN paracetamol or NSAID IVPR. Analgesic requirements usually surprisingly low. Antiemetic, as required. Special considerations: beware of air emboli during dissection, early detection by sudden fall in echo 2. Status post for laryngectomy patients presenting for surgery, to ventilate via stoma, use pediatric face mask turned through 180 degrees, LMA applied to neck or intubate awake after LA spray to stoma. Tracheostomy tube insertion is usually easy, though check stoma for stenosis or tumor recurrence, and always pre-oxygenate. Partial laryngectomy, with laryngeal reconstruction and temporary tracheostomy, favored by some as alternative to radiotherapy in early laryngeal tumors. Bone cement implantation syndrome. Bone cement implantation syndrome, BCIS, is a potentially fatal complication of orthopedic surgery, involving pressurized bone cement. Characterized by hypoxia, hypotension with LOC. Incidence: 20%. Severe reaction causes CVS collapse, 0.5 to 1.7% incidence. Hemiarthroplasties are associated with more incidence of BCIS. When does it happen? During cementation or reaming, prosthesis reduction, tourniquet deflation. Clinical features: hypoxia, decreased MAP, arrhythmias, LOC, pulmonary hypertension, cardiovascular collapse or arrest. Types: non-fulminant, decreased SpO2, hypotension, fulminant BCIS, CVS collapse. Arrhythmias and shock. Donaldson grading: grade 1, moderate hypoxia, SpO2, 94%, or hypotension, fall in systolic blood pressure, 20%, grade 2, severe hypoxia, SpO2, 88%, or hypotension, fall in systolic BP, 40%. Unexpected loss of consciousness, grade 3, cardiovascular collapse requiring resuscitation. BCIS pathophysiology. There are two theories: embolic theory, cement pressurization, fat, marrow. Air emboli enter circulation, pulmonary embolism, PVRRV strain, CO, hypoxia and hypotension. Multimodal theory, monomer toxicity, myocardial depression, vasoactive mediators e.g., serotonin, histamine, complement activation, systemic inflammation. Patient factors: elderly, fragile, cardiopulmonary status, management. Identify high risks. Cement curfew intra-op roles. 1. Risk factors: identification of patients at high risk of cardiorespiratory compromise, increasing age, significant cardiopulmonary disease, diuretics, male sex conditions. Increasing BCIS likelihood may facilitate migration of marrow contents into the circulation, increasing the risk of emboli and BCIS. Osteoporosis, potentially increasing vascular channel size or fragility. Bone metastasis may alter bone structure and increase risk of emboli. Concomitant hip fractures, additional trauma may increase risk of marrow contents entering circulation. 2. Preparation of teams, and identification of roles in the event of a severe reaction. Pre-op planning, multidisciplinary discussion, role identification, team briefing, WHO checklist, communication between teams, cement curfew protocol. Coordinated team effort during prosthesis insertion, cemented versus uncemented implants, consider patient's risk factors. Cement curfew, preoperative planning, identify cemented hit cases during the team brief. Discuss monitoring needs and cementing technique. Assign and document roles on the cement curfew sheet at the end of the timeout. During cement curfew, scrub nurse announces the start when cement prep begins. All team members return, music is turned off. Anesthetist ensures good cardiac output and increases BP monitoring frequency. Surgeon informs team when cement, prosthesis, and hip relocation occur. Cement is inserted using a third-generation technique, typically without pressurization. Anesthetist announces the end of the curfew. If cement syndrome occurs, anesthetist alerts the team and assesses for cardiovascular collapse need for CPR. Team performs emergency rolls. Once stabilized, return patient to lateral position and close hip quickly but formally. Recognize early signs, GA, sudden drop in systolic BP or end-tidal CO2, suspect RV failure, RA, dyspnea, altered mental state. Immediate management, administer 100% oxygen. Secure airway if needed. Initiate invasive monitoring if not already in place. Treat as acute right ventricular failure. Begin early, aggressive resuscitation. If severe or peri-arrest, follow ACLS protocols. Use fluids to maintain preload. Inotropes e.g., dobutamine, for contractility. Vasopressors e.g., phenylephrine, noradrenaline, for BP support and myocardial perfusion. Post-op care, continue inotropes vasopressors as needed in ICU. Monitor less severe cases in HDU for at least 24 HRS. Key point, BCIS is usually transient and reversible with prompt supportive care. Enhanced recovery after surgery. Enhanced recovery is a combination of elements of care for elective surgery which aims to optimize pre-operative preparation for surgery, avoid iatrogenic problems such as postoperative ileus, minimize the stress response to surgery, speed recovery and return to normal function, early recognition of abnormal recovery and intervention if necessary. The stress response to surgery and trauma. Surgery and trauma induce complex metabolic, hormonal, hematological and immunological responses in the body and activate the sympathetic nervous system. Triggers for sympathetic nervous system, cytokines, IL-6, TNF released by leukocytes and endothelial cells at the site of injury. Hypotension, via baroreceptors. Hypoxia via chemoreceptors, nociceptive input. Anxiety distress, via limbic system and cerebral cortex. Hypothalamus directly stimulates SANS ACTH. Cortisol 1. Sympathetic response, alpha-1, vasoconstriction, glycogenolysis. Beta-1, HR and contractility. Beta-2, bronchodilation, vasodilation. Metabolic, glucose, lactate, free fatty acids. Renin-angiotensin-aldosterone system. Na plus water retention. 2. Hormonal response, cortisol, hyperglycemia, insulin resistance, immunosuppression. ADH, water retention. GH, protein synthesis, lipolysis, anti-insulin effects. Prevents glucose uptake by peripheral cells and ensure plenty supply for brain. Insulin, relative deficiency and resistance worsens hyperglycemia. 3. Metabolic effects, protein and fat catabolism. Gluconeogenesis and ketone production. Energy prioritized for vital organs. 4. Immunohematological changes, leukocytosis, lymphocytosis, hypercoagulability, fibrinolysis, cortisol-induced immunosuppression. Key point, stress response aims to preserve perfusion, mobilize energy, and initiate repair, but may cause adverse metabolic and immune effects. Detrimental effects of the stress response. Overall, the multi-system effects of the stress response led to many potentially harmful effects including increased myocardial oxygen demand, increasing risk of ischemia, hypoxemia, splanchnic vasoconstriction which may impact on healing of anastomoses, exhaustion of energy supplies and loss of lean muscle mass, leading to weakness of both peripheral and respiratory muscles if severe, impaired wound healing and increased risk of infections, hypercoagulability, sodium and water retention. Components of enhanced recovery pathways. ERP. 1. Pre-admission, primary care, optimization, control anemia, diabetes, hypertension, lifestyle, smoking and alcohol cessation. assessment, risk stratification e.g., CPET, shared decision making, education on expectations, discharge planning 2. Preoperative, hospital, day of surgery admission, due to prior full prep avoid, bowel prep and prolonged fasting, associated with ileus, dehydration, and electrolyte imbalance. Carbohydrate loading, reduces catabolism, insulin resistance, and muscle loss. No sedative premedication. Key point, ERPs aim to reduce surgical stress, support early recovery, and promote patient engagement across all phases of care. 3. Intraoperative care in ERPs, minimally invasive techniques e.g., laparoscopy, preferred. Short-acting anesthetics, avoid long-acting opioids. Thoracic epidurals for colorectal surgery. No drains or NG tubes in elective cases. Goal-directed fluid therapy, avoid overhydration. Maintain normothermia. Thromboprophylaxis. PONV, risk stratify and treat aggressively. 4. Anesthetic factors, avoid high-dose opioids sedation, respiratory depression. Use short-acting agents e.g., fentanyl, remifentanil, Tiva. Avoid sedative premeds e.g., benzos, clonidine due to delayed recovery. Epidurals, especially for colorectal surgery, reduce stress response and ileus. Regional anesthesia supports early mobilization in MSK surgery. PONV management, risk stratify, APFL score. Moderate risk, dexamethasone induction or 5-HT3 antagonist, and high risk, Tiva plus dexamethasone plus 5-HT3/droperidol metoclopramide. Treat aggressively if PONV develops. 5. Postoperative care and enhanced recovery, early oral intake, including card drinks encouraged, reduces infections and length of stay. Minimize IV fluids once oral intake resumes. Remove drains catheters early. Multimodal analgesia, regular paracetamol plus NSAIDs. Minimize IV opioids, allow oral for breakthrough pain. Adjuncts, gabapentin pregabalin, opioid sparing. Early mobilization, sit out of bed 2H on surgery day, 6H day thereafter. Goal-directed daily plans. Patient involvement, key for adherence and recovery. Physiotherapy and mountain daylight time involvement. Essential criteria-based discharge with 24H follow-up call. Regular audit review for compliance and quality improvement. Benefits and evidence of enhanced recovery pathways, ERPs, patient benefits, faster recovery, less pain, fewer complications, shorter hospital stay, quicker return to normal life. System benefits, reduced bed days, improved efficiency, lower costs, £35, 52 million year savings, and no rise in serious complications. Evidence, meta-analyses show reduced length of stay and complications. Additional gains, better patient experience, stronger multidisciplinary teamwork, and improved primary-secondary care integration. Awake craniotomy, Oxford. What is awake craniotomy? Awake craniotomy is a brain surgery performed while the patient is awake, allowing real-time neurological testing during the operation. It's especially used when removing tumors from eloquent brain areas, regions responsible for critical functions like movement, sensation, and speech, so these functions can be protected. Procedure, tumor excision in eloquent cortex. Epilepsy surgery, DBS electrode implantation duration, 1.5 hours. Pain, variable plus to plus. Position, depends on lesion location. Blood loss, 100, 2000 ml. Group and save practical notes, LMA and arterial line. Why do awake craniotomy? Better tumor removal in critical areas, which can improve survival. Fewer complications after surgery like nausea and vomiting. Less time in the hospital, and possibly no need for intensive care. Real-time monitoring means surgeons can stop or adjust if important functions are affected. Anesthetic approaches. There are different ways to manage anesthesia. Local anesthetic, LA, with or without conscious sedation. General anesthesia, GA, with the patient woken up temporarily for testing, then sedated again. Intraoperative testing involves stimulating parts of the brain to check for speech or movement issues. This is called cortical mapping. It helps identify safe areas to operate but may trigger seizures. Preoperative considerations, same prep as for any craniotomy, plus extra attention because the patient is awake. Both a neurosurgeon and anesthetist must be skilled in this technique. Careful patient selection is critical. Absolute contraindications: surgery shouldn't be done, patient refuses, can't stay still, is confused or cognitively impaired. Relative contraindications: surgery might be more difficult, anxiety, cough or obstructive sleep apnea, OSA. Communication issues, other pre-op prep, discuss the procedure ahead of time to reduce fear and improve cooperation. Give anti-reflux meds to prevent aspiration. Avoid sedative pre-meds so the patient stays alert and cooperative. Start anticonvulsants for everyone to prevent seizures. Give dexamethasone, a steroid if operating on a tumor, to reduce brain swelling. Perioperative, surgical phases. 1. Opening phase, from skin incision to dural opening. 2. Resection and functional testing, removal of the lesion while the patient is awake and tested. 3. Closure phase, from end of resection to skin closure. Anesthetic goals: maintain adequate sedation and pain control, ensure stable heart and lung function, avoid high CO2 hypercapnia, nausea, and vomiting, keep the patient awake and cooperative during testing. Other key points: standard monitoring used, same as regular craniotomy, including urinary catheter if surgery is long. Patient positioning depends on the tumor location, awake positioning can ensure comfort. Scalp block or local infiltration is crucial for numbing and comfort. Anesthetic techniques: 1. Asleep, awake, asleep. General anesthesia GA for the start, awake for testing, then GA again for closure. Often uses TIVA, e.g., propofol plus remifentanil with an SGA supraglottic airway, and IPPV ventilation. Pros: better control of airway and CO2, avoids sedation-related issues like airway obstruction. 2. Conscious sedation, patient is sedated not fully under GA and remains spontaneously breathing. Drugs: propofol, remifentanil, dexmedetomidine. Pros: better testing participation, fewer opioids, vasopressors, shorter hospital stays. Challenge: balancing sedation, too much equals airway problems, too little equals discomfort, pain. Complications to watch for: seizures, failed testing, unexpected conversion to general anesthesia. Postoperative care: give a long-acting opioid, e.g., morphine or oxycodone at the end of surgery for pain control. Patients are monitored in a high-care area or HDU for neurological status and consciousness. Sedation and ventilation may be required if cerebral edema or decreased consciousness persists. Mild to moderate pain is common, typically managed with codeine plus paracetamol, with oral morphine for breakthrough pain. Special considerations: pre-discuss seizure management and emergency airway strategies with the team. Maintain a calm, quiet theater environment. Use transparent drapes to reduce patient anxiety and allow easy access to the airway during surgery. NSAIDs should be used cautiously due to bleeding risk, often delayed or avoided. Scalp blocks can help reduce systemic opioid use and improve comfort post-operatively. Posterior fossa surgery procedure, tumor excision debulking, vascular surgery, foramen magnum decompression. Duration: 3 to 14 hours. Pain, variable plus to plus. Position, based on surgical site. Blood loss: 100, 2000 ml. Group and save practical notes. Et. IPPV, arterial line, consider CVP and V monitoring anatomy and risk. Posterior fossa houses brainstem, cerebellum, and cranial nerve nuclei, vital for respiration and cardiovascular function. Lesions here can cause hydrocephalus, impaired consciousness, and loss of airway reflexes. Common indications: tumors, vascular malformations, cysts, cranial nerve lesions, and craniovertebral abnormalities. Preoperative: assess airway, consciousness, aspiration risk, and pulmonary function. Evaluate ICP and treat hydrocephalus if present. Correct dehydration and electrolyte imbalances. Screen for cardiovascular issues, e.g., hypertension, cardiac shunts. Perioperative monitor for V, nerve injury, e.g., EMG, SSEPs, and brainstem function. Use NGT if bulbar dysfunction likely. Be prepared for sudden cardiovascular instability during surgery. Balance smooth extubation with assessment of airway protection. Positioning: sitting, best for midline access, improves venous drainage. Risks: V, paradoxical embolism, quadriplegia. Contraindicated in right to left shunts or cerebral ischemia. Prone, common, avoid sitting risks. Ensure no abdominal compression to maintain venous return. Lateral, ideal for lateral lesions. Protect pressure points and avoid neck vein obstruction. Postoperative care extubation. Most patients can be safely extubated and managed in a neurosurgical HDU. Airway risks. Watch for obstruction due to macroglossia, vagus nerve injury, or excessive neck flexion. Respiratory drive. High cervical or medullary surgery may impair respiratory control. ICU indications: poor pre-op condition, extensive surgery, cerebral edema, weak cough, or intraoperative complications warrant ICU admission and possible ventilation. Special considerations: acoustic neuroma surgery, facial nerve monitoring via evoked EMG, NMBA only at induction. Preservation of hearing. Eighth nerve function is monitored. Use Tiva, propofol plus remifentanil to maintain consistent anesthetic depth for accurate neurophysiological monitoring. Management of obstetric hemorrhage, ATOTW. Introduction and causes of maternal deaths. Obstetric hemorrhage is a major cause of maternal morbidity and mortality. Among leading causes of direct maternal death in developing countries. Contributing factors to mortality include delayed recognition, inadequate resuscitation, poor multidisciplinary coordination, limited access to emergency interventions. Definition of major obstetric hemorrhage. There is no universal definition, but common criteria include blood loss, 1,500 ml Hb drop, 4 GDL transfusion of 4 units of packed RBCs. Etiology: antepartum hemorrhage, AF. Bleeding after 24 weeks, placenta previa, placental abruption, uterine rupture, trauma, postpartum hemorrhage, PPH, primary, within 24 HRS, 4 Ts, mnemonic, tone, uterine atony 80% of cases, tissue, retained products, trauma, genital tract injury, thrombin coagulation disorder, secondary, 24 HRS to 6 weeks, often due to retained products or infection, e.g., endometritis. Signs and symptoms: pregnancy alters normal physiology, making signs of blood loss subtle and sometimes delayed. Early warning signs: tachycardia may be the only sign until 30 to 40% blood loss. Tachypnea, pallor, oliguria, abnormal CTG. Fetal distress may precede maternal signs in AF. Later signs: hypotension, cool peripheries, decreased consciousness, metabolic acidosis, cardiovascular collapse. Challenges to assessment: language barriers, obesity, preeclampsia, beta blockers, dark skin pigmentation, masking pallor. Management of unanticipated hemorrhage. Priorities: early recognition, rapid resuscitation, treat cause. Steps: high flow oxygen, left lateral position, if pregnant. To avoid aortocaval compression, 2 large bore, 16 GIV lines, bloods, HB, crossmatch, coagulation screen. Use warmed fluids, transfuse O-negative blood if urgent. Escalate early. Senior anesthesia, obstetrics, hematology and invasive monitoring. Anesthetic management: general anesthesia is preferred in unstable patients. Ketamine 1.5 mg kg IV preferred. Cautious use of thiopentone or propofol. Avoid regional anesthesia if coagulopathic. Early arterial line placement if feasible. Central access only if time and stability allow. Monitor for fluid overload and dilutional coagulopathy. Do not delay resuscitation in attempt to access invasive monitoring. Uterotonic drugs: 1. Oxytocin root, IV bolus followed by infusion dose. 5 IU IV bolus, given slowly to avoid hypotension. Infusion. 10 IU hour for 4 hours. Notes: rapid IV bolus may cause vasodilation and hypotension, especially in unstable patients. 2. Ergometrine, root, IM or slow IV dose. 500 micrograms mcg. Note: avoid in preeclampsia or hypertension, can cause severe hypertension, may cause nausea and vomiting. 3. Carbaprist, prostaglandin F2 Greek letter alpha, e.g., hemabate, root, IM or intramyometrial, off-label, dose 0.25 mg IM every 15 minutes, up to a maximum of 2 mg. Note: use with caution in asthma, can cause bronchospasm. Other side effects: hypertension, pulmonary hypertension, diarrhea. 4. Misoprostol, prostaglandin E1 analog, root, oral, sublingual, or rectal dose. 800-1000 micrograms. Notes: useful as adjunct therapy. Minimal side effects, low cost, and doesn't require refrigeration. Surgical management if medical measures fail. Surgical options include: 1. Bimanual uterine compression. 2. Uterine compression sutures, e.g., B. Lynch suture. 3. Balloon tamponade, Bakri, Rush, or Sengstocken-Blakemore balloon, inserted into uterus, filled with sterile water, left for 6 hours. 4. Artery ligation, uterine ovarian internal iliac artery ligation. 5. Peripartum hysterectomy, life-saving but last resort, complex due to edema, vascularity, and distorted anatomy, radiological management. Uterine artery embolization, performed by interventional radiologists, requires hemodynamic stability and access to IR suite occlusion of bleeding vessels using coils or particles balloon occlusion catheters, placed pre-op in high-risk cases e.g., placenta accreta, can reduce bleeding during cesarean section. Limitations, not always available, may delay definitive management. Possible adverse fetal outcomes. Transfusion practice. Early balanced transfusion. Avoid excessive crystalloids. Dilutional coagulopathy. Use TEG or ROTM to guide transfusion. Maintain normothermia to prevent coagulopathy. Monitor for hyperkalemia from stored blood, hypocalcemia. Citrate in blood binds calcium. Intraoperative cell salvage. Safe and cost effective in obstetric cases. Reduces need for donor blood use. Leukocyte depletion. Filter delay suctioning until amniotic fluid is cleared. Salvaged blood lacks clotting factor. Supplement if needed. Additional drugs. Recombinant factor via Novasivan registered sign. Use as last resort. Dose 90 mcg kg. IV stimulates thrombin burst. Promotes clotting. Requires normothermia and pH 7.2. Risk of thrombosis. MI, stroke. DVT. Tranexamic acid. Antifibrinolytic. Stabilizes clots. Dose 1 gram IV slowly. Repeat after 4 hours if needed. Reduces bleeding, transfusion needs, and maternal death. Now standard part of PPH protocol. Subsequent management. Risk of rebound hypercoagulability. Post hemorrhage. Initiate pharmacological thromboprophylaxis. Early use. Graduated compression stockings. Assess for VTE risk and manage accordingly. Key points. PPH is a major, often preventable, cause of maternal mortality. Requires early detection, rapid escalation, and team-based care. Always treat maternal life as priority. Use protocol-eased approach for drugs and escalation. Hypothermia, coagulopathy, and acidosis are deadly triad. Avoid it. Newer options like interventional radiology and cell salvage show promise. Hypertensive disorders of pregnancy. Hypertensive disorders are a major cause of maternal and fetal morbidity. Preeclampsia and eclampsia deaths are increasing, mainly due to cerebral hemorrhage. Delivery is the only definitive treatment. Pathophysiology. Inadequate placental trophoblast invasion leads to high-resistance spiral arteries, limiting blood flow to the fetus. Pathogenesis. Preeclampsia develops in 2 stages. 1. Abnormal placentation reduces placental perfusion. 2. Maternal endothelial dysfunction causes vasospasm, coagulation activation, and organ damage. Definitions and terminology. Chronic HTN, present before 20 weeks or on antihypertensives. Gestational HTN, new HTN after 20 weeks without proteinuria. Preeclampsia, HTN plus proteinuria after 20 weeks. Severe preeclampsia, HTN with symptoms and lab abnormalities. Eclampsia, preeclampsia with seizures. Grades of hypertension. Summary. Hypertension is classified based on systolic diastolic readings. Severe cases warrant immediate attention. Symptoms and associated system involvement in severe preeclampsia. Symptoms: headache, visual disturbances, blurring, flashing, upper abdominal pain, nausea, vomiting, sudden swelling of face, feet and hands, brisk, deep tendon reflexes, hematological impairment, thrombocytopenia, altered coagulation, HELLP, hemolysis, low platelets, elevated liver enzymes, biochemical impairment, kidney, altered urea, creatinine, sodium and potassium, increased serum urate, proteinuria, elevated urine, PCR, liver, low albumin and low glucose. In severe cases, elevated liver enzymes, AST and ALT, 30 IUL, LDH, 600 UL. Risk factors. The factors associated with the development of preeclampsia are as follows: pregnancy-related, first pregnancy, multiples, donor eggs, sperm, molar pregnancy, maternal, extremes of age, obesity, diabetes, chronic HTN, renal disease, paternal, first-time father, history of prior pregnancy with preeclampsia. A mix of maternal, paternal, and pregnancy-related factors increase preeclampsia risk. Maternal and fetal complications. Maternal, CVS, vasoconstriction, 55, failure, neuro, seizures, cerebral hemorrhage, RESP, pulmonary edema. renal, AKI, proteinuria, liver, rupture, abnormal LFTs, hematology, DIC, HELLP, fetal, IUGR, placental abruption, preterm labor. Both mother and fetus face serious, multi-organ complications if the condition escalates. Investigation CBC, especially platelets, liver function tests, renal function, creatinine, urate, glucose, if liver enzymes are very high, urine analysis for protein, urine protein creatinine ratio, 30 mg/mol indicates significant proteinuria. 24-hour urine collection is used for confirmation and quantification. Fetal monitoring includes growth scans and Doppler studies. Management, preconception care, encourage weight loss in overweight women. Optimize blood pressure control before pregnancy. Stop ACE inhibitors and ARBs due to fetotoxicity. Offer low-dose aspirin 75-150 mg to high-risk women. Antenatal care, close monitoring of BP, urine, and blood tests throughout pregnancy. Early referral to obstetric anesthesia clinic is recommended. Admit all women with BP 160/110 mmHg regardless of gestation. Fetal surveillance includes serial ultrasounds to monitor growth, biophysical profiles, umbilical artery Doppler every 4 weeks from 24-26 weeks if high risk, control of hypertension. Initiate treatment when systolic BP 150-160 mmHg. Target, maintain MAP, 125 mmHg while avoiding fetal hypoperfusion. First-line medications, labetalol, oral or IV, methyldopa, oral, nifedipine, oral. Severe cases may require IV hydralazine or combination therapy. Avoid rapid BP drops to maintain placental perfusion. Common medications, methyldopa, oral, sedative, avoid postpartum due to depression risk. Labetalol, oral IV, avoid in asthma and cardiac conditions. Nifedipine, oral only, causes flushing, tachycardia. Hydralazine, IV only, can cause reflex tachycardia and fluid retention. Magnesium sulfate, prevents seizures, dose carefully, watch for toxicity. ACE inhibitors ARBs, contraindicated, cause fetal renal and skeletal issues. Diuretics, not routinely used, reserved for pulmonary edema. Seizure management, magnesium sulfate is the gold standard. Loading dose, 4 grams IV over 10 minutes. Recurrent seizures, additional 2-4 G bolus. Maintenance, 1 GHR for 24 hours postpartum. Monitor for magnesium toxicity, loss of reflexes, 5 mol/L. Respiratory depression, 7 mol/L. Cardiac arrest, 10 mol/L. Intoxicity, stop infusion, start CPR, administer IV calcium gluconate. Fluid management, risk of pulmonary edema due to capillary leak and vasoconstriction. Limit total fluid intake, oral plus IV to 1 ml/kghr. Aim for urine output 0.5 ml/kghr, or 2 ml/kg over 4 HRS. Give cautious fluid boluses if output drops. Consider invasive monitoring CVP, arterial line, in unstable or ICU-bound patients. Avoid fluid overload, greater risk than underhydration in these patients. Labor analgesia, epidural analgesia is preferred if platelet count allows, 100 x 10 to the power of 9/L. Epidural helps control pain-related BP spikes and may improve uteroplacental flow. Single-shot spinal may be safer than epidural if platelets are falling. If Neuraxel is contraindicated, consider patient-controlled IV opioids, e.g., remifentanil or fentanyl. Delivery management timing depends on maternal and fetal conditions, 34 weeks. Stabilize mother to allow fetal lung maturity if safe. Delivery is the only cure and improves maternal condition. Mode of delivery depends on obstetric and maternal factors. Anesthesia for cesarean section 1. Regional anesthesia, preferred technique, spinal, epidural, or combined, safe and effective. Even in severe preeclampsia, women with preeclampsia often have fewer hypotensive episodes. Titrate vasopressors carefully, may have exaggerated responses to general anesthesia, use when regional is contraindicated, low platelets, coagulopathy, ongoing seizures or postictal state, pulmonary edema with hypoxia, patient refusel, anticipate difficult airway due to edema. Blunt the hypertensive response to laryngoscopy. Magnesium, 0.5 to 1 g IV labetalol, 25-50 mg, alfentanil, 1-2 mg, avoid ergometrine and NSAIDs post-op. Continue anticonvulsants and antihypertensives. Recovery. Close observation postpartum is essential due to seizure risk. 44% occur after delivery. Continue magnesium sulfate for 24 hours post-delivery. Monitor blood pressure, fluid balance, blood and biochemical status. Provide care in high dependency or ICU settings if needed. Postpartum review. Reassess and taper antihypertensive medications over 2-6 weeks. Monitor BP regularly during this period. Counsel on future risk. 19% chance of gestational HTN in next pregnancy. 32% chance of preeclampsia. 46% chance if chronic